Assalamu alaikum. So Bismillahirrahmanirrahim, we'll be starting our next session, which is a bone marrow transplant session. We have got our chairs, which includes Dr. Sayyid Waqas Imam Bukhari. He's a consultant clinical hematologist at Shaukat Khanum and lead for BMT services. We also have got Dr. Mehreen Ali Khan online. She's co-chairing as well. She's Associate Professor of Hematology and Clinical Hematologist and Transplant Physician at Armed Forces Bone Marrow Transplant Center. We've got Dr. Bushra Hassan as well. She's a clinical hematologist at Shaukat Khanum Hospital and lead for lymphoma services. So we'll start our first talk by Dr. Mehdi Hamdani. He is a professor of internal medicine at Medical College of Wisconsin, Milwaukee. His special interest is in lymphoma, CAR T cells, and bone marrow transplantation. So over to Dr. Mehdi Hamdani.
Hi, Assalamu alaikum. So hopefully people can hear me if somebody can confirm and you can see my slides.
Yes, we can hear you.
Okay, perfect. So Assalamu alaikum. Thank you for the kind invite. I'm surprised people are at the meeting and nobody is watching the very exciting Pakistan-Bangladesh match. So keep the prayers going for the team in green. So routing back to the talks in the next, I would say about 18 or 19 minutes, I just wanted to talk about what right now is the hot topic, at least in Western practices, where we are sort of starting to debate the modern role of transplant, if any, versus cell therapies in second line in patients with aggressive lymphomas. And the prototype for this disease is obviously diffuse large B-cell lymphoma and related disorders. So these are my disclosures. My consultancy and research work for a number of cell therapy products is very relevant for this talk. So keep those disclosures in mind. So I'm going to set the stage of this talk about at least what some people would call historical perspective of transplant and cell therapy in patients with aggressive lymphomas. But I think whether you call it historical or not, I think this potential modality is very relevant for practices in South Asia and other resource-limited practice settings. So when we talk about patients with diffuse large B-cell lymphoma or similar histologies that relapse, the standard of care of these patients for a number of years have been consolidation with high-dose therapy, and these data have been out there longer than we have been independent practitioners. Me and Osman were medical students in King Edward when Parma trial was published that basically showed that if an aggressive lymphoma patient relapses, but they're lucky enough to respond to second-line treatments, then for such chemo-responding relapse patients, consolidation with high-dose therapy and autologous transplant not only provided an event-free survival benefit, but it also provided a clear overall survival benefit. Now, we also know that not all aggressive lymphoma patients, when they relapse, they benefit from auto transplant. So data from the very seminal CORAL trial had a very interesting observation. So the trial mentioned that if aggressive B-cell lymphoma patients relapse within 1 year of their diagnosis, they have a poor outcome. These patients have a median event-free survival of only 3 months. And more than half of these patients do not respond to chemoimmunotherapies, and subsequently they are not transplant candidates down the road. So when the CORAL trial was published in 2010, there was a huge movement, at least in the US practices, that if you relapse early, you should never consider about autologous transplant in these patients. And we challenged those observations because in our mind, patients can relapse in two specific patterns. You can get R-CHOP in frontline, go into a complete remission, and then relapse within a first year, which is high risk by CORAL definition, or you could have primary refractory disease. So the first question we tackled was, if you relapse early after a CR, if you relapse within a year of diagnosis, but you happen to respond to second-line therapies as autologous transplant futile. So using the registry data from CIBMTR, we led a large analysis of about a little over 500 patients, and we basically showed that whether you relapse early or not, if you're lucky enough to respond to subsequent lines of therapy, autologous transplant will cure half of those patients. And the second pattern of relapse is you get R-CHOP and you have primary refractory disease. You never go into a CR. And that analysis was led by Susan Ball and University of Alabama, collaborating with us in CIBMTR. And we again showed that if you have primary refractory disease, if you're lucky enough, and that's the key, if you're lucky enough to respond to second or subsequent lines of therapy, about 40 to 45% of those patients can be cured with high-dose therapy and autologous transplant. Now we have to critique all the data that is in front of us. So I would be the first one to acknowledge that all the CIBMTR data I've shown is an illusion of patient selection, right? Remember, if you relapse early, more than half of the patients are not going to respond to second-line therapies. If you don't respond to second-line therapies, meaning if you have chemo non-responding disease, autologous transplant is not going to do anything for you, right? So if you look at all these primary refractory patients from the Scholar-1 data set, the median survival of these patients is under 7 months. So this is clearly an area of unmet need until recently. And over the years, a number of groups have tried to improve the outcomes of relapse patients. We have looked at various chemotherapy regimens, RICE versus ICE, DHAP, so on and so forth. None of these things really moved the needle. We have tried to augment transplant conditionings by adding radioimmunotherapy or rituximab, but none of these options really changed the outcomes of these patients or improved survival. So in the recent past, the question was, if chemotherapy modulation is not going to change the outcome of these patients, can moving chimeric antigen receptor modified cell therapies in second line going to move the needle? And that was tested in 3 landmark randomized clinical trials that were published and presented in the last American Society of Hematology meeting. So these 3 trials, one trial, ZUMA-7 used XeCell, the Transform study used Lysocell, and the Blenda study used Tezacell, and these are all CD19 directed chimeric antigen receptor modified CAR T products. And in these randomized trials, the subject of the trials was aggressive lymphoma patients who relapse within 1 year of finishing their therapy. And these high-risk patients were randomized to either standard of care, and the standard of care arguably across the world at that time was salvage chemoimmunotherapy followed by auto transplant in responding patients, or taking these patients directly to CAR T-cell therapy. And these trials had design variations. Some of these trials didn't allow any bridging, and that was the ZUMA-7 trial, and the remaining 2 trials allowed some sort of bridging across both of these arms. And hopefully your very knowledgeable audience is aware of the punchline of these trials. The bottom line was ZUMA-7 trial shown on the left and Transform trial shown in the middle were positive studies. They clearly showed an event-free survival benefit in favor of the CAR T-cell therapy. And the Tezacell trial or the Belinda trial shown on the right was a negative study, and we can, in the Q&A session, think about the reasons why these studies have been negative. So clearly positive studies, clearly studies that are going to change the standard of care, but there are certain nuances with that study that when we interpret the data, we have to keep those nuances in mind. Number one thing that is remarkable is that all 3 trials in the standard of care arm showed that the response rates to salvage chemotherapy were exactly what we have known for about 12 plus years. About half of the patients respond to second-line therapies. But what is striking is that in these trials, patients, after responding to chemotherapy, there is a big drop-off in patients who responded to second-line therapy, and then there is a 14% drop-off in patients getting the autologous transplant, which is very unusual for these practices. Once you respond to your treatment, dropping off to transplant is unusual. So if you look at a deeper level at the ZUMA-7 data, so if you look at the ZUMA-7 trial, out of the 180 patients randomized to the standard of care arm, 90 patients, according to central review, responded to chemotherapy. but according to the investigators, only 80 patients were assigned a response. And this is unusual. Generally in trials, if you look at it, the central response is lower than the investigator assessed response. Here, the situation is opposite. And my suspicion is that us physicians don't like to take patients with partial remission to an autologous transplant. And we were potentially calling patients with partial remission non-responders. And then even among those 80 patients, only 62 patients made it to transplant. And this is unusual. So about 30% of responding patients never get an RO. But if you look at contemporary data of aggressive lymphoma studies, patients fail mobilizations. You can relapse in between responding and getting to transplant. And that number historically has been around 12 to 15%. So we have to interpret the observation of these trials with a little bit of caution. And the problem is that we have to recognize our bias against what we don't consider good response to therapies. And B, the problem with these trials is these trials were assigning therapies before patients started second-line therapy. But generally, at least in a US practice, that's not how patients come to a good chunk of transplant and cell therapy centers. It's very common for the referring physicians who send patients to me is they would call and say, hey, Dr. Madani, I have a patient in Green Bay, which is like 3 hours from Milwaukee, and say, I have an aggressive lymphoma patient who's relapsed, what should I do? And we would say, well, start a round of rice, I'll see the patient next week. And it is not uncommon for our patients to come and see us after already starting to achieve a partial or a complete remission. So the problem is, should those patients get an auto transplant or CAR T-cell therapy? And all these randomized trials can't really answer those questions because they were not randomizing patients after achieving chemosensitivity. So what should we do with a patient that is shown in this figure here? Somebody who arrives at your center, even with high-risk disease after already achieving a partial remission. Since none of these 3 trials can answer this very practical clinical question in CIBMTR, we were anticipating this limitation of all these 3 randomized trials. So we took a deeper dive into our registry data, and we looked at a tough question. We looked at aggressive lymphoma patients who relapsed, but then got auto transplant either in a partial remission or they got to CAR T-cell after achieving a partial remission. And we wanted to see if one modality outperforms the other modality in this setting. So in this study, we had about 266 auto transplant patients, 145 CAR patients. The age of these patients, the primary refractory disease status of these patients, the proportion of patients with double hit or triple hit was fairly well balanced, and the bulk of disease was also well balanced. So with these things in mind, when we look at the outcome, I'm not going to claim that in partially responding patients, auto is superior, although that's what the analysis showed. But I think a conservative interpretation is going to be that no, maybe we don't see a clear signals that chimeric antigen receptor modified therapies outperform conventional transplant platforms in patients who are responding to chemotherapy. Now, a limitation of our study was that it wasn't a study that was restricted to second line. So we did a subgroup analysis where we limited patients to patients who have gotten no more than 2 prior lines of therapy. And again, we were unable to show a superiority of CAR over autologous transplant in that setting. Now, another criticism of this analysis is that maybe auto may work better for patients with low bulk disease and CAR will work better in patients with partial response, but more bulk or with higher bulk disease. So we did a subgroup analysis where we stratified the disease by remaining bulk at the time of transplant or CAR T-cell therapy, or whether, so when we look at it with disease bulk, whether patients had the largest lymph node under 3 centimeter or 3 to 5 centimeter or more than 5 centimeter, again, we were not able to show any superiority of one modality over another. And then these sort of like observations are kind of consistent with some supplemental data from ZUMA-7 trial. So in ZUMA-7 trial, they never showed clearly the data of patients who actually got to auto transplant versus axi-cell. But if you look at the median duration of responding patient across the axi-cell and the standard of care arm, which is a rough approximation of our analysis, you don't see a marked difference with either modality, which sort of confirms the observations that we produced in the CIBMTR study that I just showed. Now, a more provocative question is, well, PR is a tricky scenario. What are we going to do with our early relapsing patients who get to our transplant and cell therapy centers after achieving a complete remission? Because in complete responding patients, if you look at patients who get to auto transplant with a negative PET scan, their 4-year event-free survival is sitting at around 70%. So are we really doing these patients any service by offering them cell therapies? I'm really, really skeptical of that point of view. Then we are, even in a US model, we have to think about CAR. And these cost analysis, I would caution, are very difficult to interpret. I'm not a health economist. I have trouble understanding these analyses, but in my life, I've never seen a drug company do an analysis and then come and say that our drug is not cost effective. And a good example is you can see that the analysis done by one of the CAR T cell manufacturing sponsors shows that their product is cost effective. But when the same analysis is done by an academic, independent academic group with different assumptions, the cost estimates are not even in the same ballpark. So keep that cost question in mind when you think about CAR versus auto transplant. So the next question becomes like, am I advocating a one size fit all for all DLBCL patients getting an auto transplant if they achieve a PR? And no, I would humbly argue that it is not that straightforward. For a number of years, we have known that the double hit lymphomas of the world or the triple hit lymphomas of the world, when they relapse, even when they have chemo-responsive disease, they do not benefit from an auto transplant. So in my practice, if I see a double hit patient relapse, even if they achieve a complete or a partial remission, I would probably take that patient to CAR therapy because I don't think these patients benefit from an auto transplant. There are other clinical predictors of predicting futility of autologous transplant. So this is an analysis we did with Luciano Costa and University of Alabama, where we looked at early relapsing aggressive lymphoma patients, and we identified 3 poor prognostic factors at the time of relapse shown in red. If patients were getting CHOP therapy and they had primary progressive disease, meaning patients were blowing through R-CHOP, or patients with high IPI score, or patients with c-Myc gene rearrangement on FISH analysis, predicted 3 adverse factors. So patients who have at least 2 of these red adverse risk factors, even if they respond to chemotherapy, they usually are not cured with auto transplant. And this is shown in the curve at the very bottom. Their long-term overall survival is only 13% with an auto transplant. And somebody who fulfills these high-risk criteria that we call the refined study criteria, I'm reluctant to take these patients to a simple autologous transplant. And then the big group is older patients, right? Somebody who's in their 70s. You can probably do an auto transplant on a very fit 75-year-old, but maybe not an 80-year-old. So if an 80-year-old patient relapses, what are we going to do for those patients? And for those patients, the pilot study was very important. So pilot study was a single-arm open label study where our center also enthusiastically participated. It was a study for patients above the age of 70 or patients with cardiac comorbidities or renal comorbidities. And those patients, when they relapsed, were taken to CAR therapy directly. And that study clearly showed that CAR in second line for older unfit patients produces very high response rates. And in complete responding patients, it appears to be a curative therapy for a subset. So in 2022, how my program is approaching transplant versus cell therapy in second line for aggressive lymphoma patients. So I don't think one size fits all. So when an aggressive lymphoma patient relapses, we ask a few questions. Does patient have any ultra high risk features? Is it a double hit lymphoma patients with c-Myc gene rearrangements with BCL2? Does the patient have high risk refined study criteria? Is the patient even fit enough for auto transplant? Is the patient at extreme of advanced stage, or does the patient have primary refractory disease? If the answer to these questions is no, I think thinking about auto transplant, even in centers with access to CAR T cell therapy, is reasonable. If somebody comes to my program after already achieving a complete or a partial remission, I'm very comfortable giving that patient cell consolidation with autologous transplant. However, if patients have these high-risk features shown in black, I think CAR T cell therapy in second line is clearly standard of care. And then these therapies, at least in one direction, are not mutually exclusive. If you attempt auto transplant on a patient and they relapse, you can very easily take that patient to CAR in third line. I'm skeptical of the feasibility of this combination in the reverse sequence. So that's sort of how our practice in 2022 is evolving. It's a very interesting time for managing patients with aggressive lymphoma. Soon it's going to get super complicated when bispecifics hit the clinic as well. So hopefully I kept to time. This is my contact information if anybody wants to connect offline. Again, I'm grateful for your kind invitation. Huge fan for your cancer center and all the amazing work your program has been doing for decades, and keep the prayers going for the team in green. Thank you.
Questions.
Thank you, Dr. Mehdi. We'll get questions and answers now for his session. Now, we'll get it now if you want to. Yeah.
So there's a mic.
One question. Maybe 1 year, 2 years to me, medical school, that's the only place he was behind. we look forward to his talks and learn from him. So when we have zero experience with CAR T in this country, but my understanding is when you talk about auto transplant, you're talking about a monolith. Everybody's getting beam. When you're talking about CAR T, as from the Belinda study, they're not all the same. There's types of CAR T that takes like 56 days to prepare versus 12 days to prepare. Your patients may relapse in the meantime. So that was one thought. Especially when we do a meta-analysis of the CAR studies versus auto, you're comparing a diverse group of patients to sort of a monolith. The other question was, there was a study last week about allogenic transplant in DLBCL in patients who have failed CAR T, and that salvaged about 1/3 of them, which is very encouraging for our part of the world. That is something we can still offer. So your thoughts. Thank you.
Yeah, you're absolutely right. And thank you for reminding me of the fantastic days we had in King Edward. Yeah, so I think the problem with T-cell cell is not just the slow turnaround in manufacturing. There is actually a very interesting Nature Medicine paper where, just using European registry data, they compared T-cell cell against XC cell using propensity score matching. And even after you adjust for manufacturing issues, T-cell cell appears to be an inferior CAR. So I think Belinda trial is negative for a number of reasons. You're absolutely right that it is probably negative because of manufacturing issues, and maybe it's not as good of a CAR product as Lysocell or XC-cell. And I think even in US practice, I think allotransplant, the numbers are going down, but it is still a relevant practice. The allo salvage paper that you're referring to in Hematologica was led by one of our fellows, Joanna Zerko, and we are still doing allos after CAR failure. The problem is once you fail CAR, allo, just like an auto transplant, is a consolidation for chemo-responsive patients, right? So it's not very easy after CAR failure to get patients into a remission. And if they get to a remission and a donor is available, yes, I absolutely agree that a subset of those patients are curable with an allo. But the problem is most patients after CAR generally don't respond to therapies.
Any other questions? Thank you, Dr. Mehdi. I have a small question.
Sure.
When and how do you plan to send us the CAR T cells?
Well, I think, so see, like Pakistan is a resourceful country, right? And if King Faisal can do CAR T cells, or if India can do CAR T cell, why can't we, right? So there are manufacturing platforms where you can think about generating your own CAR T cells. The easiest route to CAR T cell, by the way, is create a GMP compliant facility in Shaukat Khanum, right? You can work with Miltenyi to get their tabletop devices. You can send a couple of your cell processing lab people to MCW. We are happy to train them to how to generate CAR using the vector from lentigen and then sort of like doing the cell propagation in the Miltenyi device. Or, yeah, be in Pakistan, right? Trust me, CAR-T, there is no rocket science behind CAR-T cells, right? Shaukat Khanum has been doing beautiful work for decades. CAR-T cell is bananas, right? It's just about putting the right resources and the right team there, and I have no doubt that your team can have access to that therapy.
Thank you very much. We'll keep in touch, inshallah.
Sorry,
Thank you very much.
one quick question, Dr. Mehdi. So am I correct in saying that XeCell, for instance, which showed better results and was a positive study, there were higher toxicities and neurotoxicity as well. So is it in the CAR which is showing better results is also showing higher toxicities as well?
True, right? So XeCell has a co-stimulatory domain, which is CD28, right? So all CD28 co-stimulated CARs have a slightly higher risk of neurotoxicity. There is some data that you can prophylax these patients with dexamethasone and the neurotoxicity rates come down. But yeah, that's clearly a more frequent side effect with XeCell compared to lysosol.
We have another question from
Yeah.
Dr. Ramina Ghazi.
Yeah, because he encouraged me to ask this question. He said that they are producing CAR T cells in their lab. Being one of the molecular biologists at Shaukat Khanum and dealing with diagnostics, I was just wondering that you are producing these CAR T cells in BSL-2 labs. I'm sure you wouldn't know that because you don't do it yourself, but just wondering, like, do you have BSL-3 or higher labs that you produce your CAR T cells, or because you're dealing with lentiviruses?
So what we do is we buy a vector from Lentigen, right? So Lentigen is a company that creates vectors, and the cell propagation happens in a GMP compliant facility, right? So there are many ways of generating CAR T cells, right? So if you go to Michael Sedlin's lab, they're generating CAR T cells the old-fashioned way in bags. We took the strategy where we basically do all CAR T cell transfection work in a self-contained device. It's a tabletop Miltenyi device. And our group was the first one that did it, but now a number of centers are doing it. Mayo Clinic is doing it. It's being done in India right now, by the way. And I believe the team from King Faisal was at my center about a year ago, and they bought those devices. I don't know if they're actually doing it, but they're trained to do it. So
that means it is not from scratch, like you isolate lymphocytes and you do everything from scratch. You don't do that. You have more of a like machine equipped, like we are talking here in Shaukat Khanum that we want to do. Okay, thank you.
Correct. It's not a very hands-on process.
Thank you very much, Dr. Mehdi Hamdani. We'll move to our next talk now. We have Dr. Sadia Javed Khan. She's a pediatric oncologist all the way from Saudi Arabia. She's a consultant in King Faisal Specialist Cancer Hospital and Research Center. Dr. Sadia will be giving us a talk on haploidentical bone marrow transplant in children.
Thank you for the invite, and it's hard to follow that talk, right? It's awesome. But kids are much simpler, and my talk's going to be a little more simpler, and I have no financial disclosures, unfortunately. But the way I planned this talk was to think of something, to bring an idea and have people work around it, right? Because it's very easy to talk about CAR T cells and all this fancy stuff, but CARs are not a walk in the park. Honestly, it takes a village to get these kids going, and it takes a lot, and money. That's part of it. But we'd love to have, I think, a bi-directional conversation here. And please feel free to interrupt or ask questions as we go. Okay, so the question is now, why haplos, right? We historically are doing very well with sibling data, with siblings as donors. And so why do we have to mix and match? But there are times when, you don't get a sibling donor and, you don't get one in the MUD registry. And then you have to look for someone who's a mismatched, unrelated, or the easiest, again, we don't appreciate our parents enough, but they're always there for us. So for us, for our pediatric population, we can always go to the mother or the father and we can ask them to be donors. And believe me, I don't think anyone has ever said no to us, if we've asked for the parents to donate. Now, in my last session, we also had med students with us and we had trainees. So a haplo-identical donor just shares one haplotype, right? So that's what you need from your mother or your father. And if you have a little more unshared alleles from the unshared haplotype, then you become a family donor, a mismatched related donor, right? So now the decision of, what sort of a donor are we to use comes from the experience of your center. What is your center equipped for? What is your center looking for? What's your vision? What do you have available for yourselves? What are your resources? And then you decide. You just don't wake up one morning and say, we're going to be a haplo-identical transplant center. But in my heart of hearts, I believe for countries like ours, maybe haplos are the way to go. Imagine, the work you need to put in for a MUD registry, whereas you can easily invest in DSAs and lab parameters, and you can easily use your parents or siblings, as haplodonors. But again, we'll love to see what the experts have to say about this. Now, we'll go with a patient scenario, and we'll see how this works out. So this happened, actually, COVID taught all of us a lot about different aspects in life, but also taught us about stuff in transplants as well. So I'll talk about this patient. She was diagnosed with intermediate risk AML. And in the pediatric population, we have intermediate AMLs. And if we have a sibling donor, we go for transplants. Correct me and we'll see what the adults do, right? And this was happening for us, just for perspective, historical perspective. This happened to us Shane came to us in around June, July of 2019. And this was when we, as the kingdom, we went into curfew, into full lockdown. So we decided to get the sibling, but we had to get special permissions for the sibling to fly to Riyadh to get harvested. And usually we do fresh, we are proponents of fresh, but in COVID, we just shifted completely to pre-harvested donors, and all of them were cryopreserved. Now, the issue with this donor was she was a 2-year-old and she was also an ABO mismatch. So it made more sense for us to pre-collect. And this is what we do. Now we only do pre-collections when we have a mismatch of size or ABO. So everything was going fine. She got a Bucite conditioning regimen, but soon day 0 arrives. And as soon as the product's infused, just a minute or two into it, she codes, there is a flat line. We resuscitate her for a couple of minutes and we revive, we stop the product and she goes to the ICU. Now, the question is, what was wrong? What happened? Was the graft flawed? Was the cryopreservation not done right? Was it the DMSO? I don't know if anyone's seen that, but in my short career span, this is the first time that I was told a kid had coded with a DMSO. I've never seen that, honestly. There are infusion reactions, lots of infusion reactions, but you can get on top of it, but not to the extent that, you have to do a CPR on a 6-year-old child. So what would anyone have done? What would have been your second go-to? So, I mean, now you're stuck, you're 0, the child's fully neutropenic.
Certainly not giving that product again.
Absolutely, that was, we did that.
Do you have any auto?
We did not auto collect because we were overconfidence. Sorry? Because that's my talk.
Was the sibling?
No, we did not think of haplo for the parents, Dr. Ayaz. Sorry, not putting you on the spot, but. Right. Right. Get us in a lot of trouble. We're stuck, right? So then we ask for the 2-year-old girl to be sent over. right? I mean, what do you do? So we got the sibling and we thought, okay, maybe it was the DMSO, right? So what if we just harvest her peripherally, right? So we beg our surgeons and they get us a GAMCAT and we get a PBSC graft. But I think luck was not in our favor, right? So now the bag clotted for us. So I thought it was the donor, something with the hematologic issues that she just clotted, and there was no way we were going to give a product with clots to a patient, right? So we said, okay, that's also not happening. Then we asked the parents. So now we asked the mother and the father. But also, we forgot to use umbilical cord blood. We had also entertained the idea of a cord blood because of her size. We could easily have done a single or a double. But again, we were thinking of the DMSO part and we did not want to lose time. So we thought the cord blood was not an optimal graft for us. Then we went to the parents and we tested the parents, and the parents were COVID-19 positive. And that is when, you know, all this data was coming in. So we honestly did not know how safe was it to get a graft from a COVID-19 positive patient and give to the child. So then what did we do? Oh, no. Back then we were still stuck and we said, okay, who else do you have with you? Who's traveling? And they said, we have a brother traveling with us. And we said, okay, you know, he's a 16-year-old man, kid. He's going to be our donor. And so this was now, we're talking about 2 weeks out. So we're 2 weeks out. We had to adjust our conditioning a bit. Ideally, we would have gone with a Bu, Flu, Thiotepa, ATG based regimen. So we just added an ATG and fludarabine to her regimen, and we decided to go with the haplo from the brother. Just because I've told you such a long story, now she's around 2.5 years out to 3 years out. She's doing very well. Alhamdulillah, she's still in remission. But again, the acute phase was difficult for us, right? The acute GVHD part was a tricky part for the child and for us as treating physicians. This is just a little something about, you know, whenever you're going to be thinking, we always have to keep your heme path lab involved, because you also need to look for donor antibodies, right? You really can't miss that part, because then you just you'll just lose your graft and it's going to be futile. Okay, so how does it work now? So of course it's available. Anyone has a donor at any point in time. I have a donor right now. My dad's my donor in case I need it. I mean, he's my haplo donor. So in case you're lacking a sibling, each one of us has a donor available. It might not be an optimal donor. And in our scenario also, you know, that was not our go-to donor. But sometimes you just have to, in case of, you know, how things work out, go for a suboptimal haplodonor. Now, because of the bidirectional alloreactivity, we will have a lot of issues with graft rejection. You will have issues with GVHD, and you will have delayed immune suppression, immune reconstitution, because you've given them a lot of immune suppression because of the haplo status that they have. Now, some people have decided to, you know, go the PT-Cy route, the post-transplant cyclophosphamide route, and some have gone with the alpha-beta T-cell depletion route. In our center, we still go with the conventional PT-Cy route. We don't go with the ex vivo T-cell depletion and the mega doses. If there are any trainees in the room, they'll ask why cyclophosphamide and why cyclophosphamide will not destroy the stem cells. It's because it's going to act for the cycling cells. And again, we don't give it at day 0, we give it at day 3 and 4, so that we have all that CRS going on in the body. We have these alloreactive cells from the donor and the host that we can take care of. The complete understanding of the pathophysiology of PT-Cy working still not fully elucidated. Okay, so how common is it? And, you know, are we catching up? So this is IBMTR data on your left, and that's King Faisal data on the right. So you can see that green is the we have a pointer. So this is when, you know, sort of the trend caught up, and, you know, you sort of went from 1,000 to, you sort of doubled, right, in your graphs there. And we were a year late, and we caught up in maybe 2017, 2018. And now we are offering a lot more haplos. And I'll tell you, we are offering a lot more haplos to our SCID, our immunodeficient patients, right? They're just a couple of weeks old or a few months old. And rather than and we really don't want them to get these viral infections and stuff. And there's always a mother or a father by the side. So that's our major chunk. Our familial, I know the last session we were talking about HLHs. So we are offering a lot of haplos to our HLH patients because we feel that the siblings might be carrying the gene. So they might not be the most optimal donor, but if only, and it's an auto-recessive, right? So we might do well with a parent. So our major population is our non-hematologic kids. Now, we spoke about this, right? We spoke about, and I think there was this discussion about CARs. So, how do you T-cell deplete in vivo, ex vivo, and there are ways of doing it. We have gone with the Hopkins alternative method. And again, depending on what poison you choose, you decide if you're going to go with a MAC or a RIC. We usually go with a MAC, a myeloablative regimen. I don't know. It would be interesting to see what people think about priming the marrow before a haplo. Anyone wants to weigh in and say yes or no? Yay, nay? Okay. Okay. Okay, absolutely. We do a marrow, and you do a priming for just a dose or two, or like okay. 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 And maybe that's also because the adults, right? Because we don't have, we have a mismatch issue. So we don't prime ideally until, and because I mean, it's the parent and it's like a 5 kg or a 6 kg baby. But sometimes, some of my colleagues argue, you want to get the cell cycling. So they might vote for a dose of GCSF or two doses of GCSF. But we're still preferring to go with a non-primed marrow, and it's been working for us fine so far. Okay, and then of course we don't the cost. We know, it's an expensive thing. You need resources. You need to invest. You need to train manpower. PTCy, on the other hand, cyclophosphamide is cheap to get, easy to give. Yes, we'll talk about the issue that we have with it later on. So far, any questions? Any burning questions? Any comments? Okay. Age limit for haplodonor? No, honestly, if anesthesia clears the donor, we don't have a problem with the donor. But usually we will probably not choose a multi-parous woman with 10 kids in our region. We have 8-9 kids easily. But yeah, I mean, if anesthesia has no issues, we have gone with mothers and we try to gender match. But usually we'll prefer a father if we get a father. Yeah, that's good. Okay. So multiple factors involved. So we're talking about, right, you have to factor in non-relapse mortality, GVHD, and how these kids do. And honestly, in terms of survival and all of this, they do very well. It's just the chronic GVHD. And I was trained in a T-cell depletion center, right? But then there you have a lot of issues with viral infections, but they also then were very good with their cytotoxic cells. So they were also a CTL center. And that's why I think they were also a T-cell depletion center. So you have to think of, what are you going to pick? And then what are you ready to deal with the complications of what's going to come? Because doing this, it's easy to do, honestly, but it's the follow-up that gets you in trouble at times. Poor remission status before you get into a graph. So I think, my entire presentation, I think this is the more, I don't know if it's, can you all see this? I think this is the crux of the thing, right? So what MRD status are you going in with? If you're talking of malignancies, okay, or what disease characteristics are you going in with? Any comorbidities, right? What's my donor having? What's the DSA status? Do I need to give rituximab a dose or two? Do I need to plasmapheresis? How high are the titers? What sort of a titer will I accept? Then the conditioning, right? Am I going to go with a RIC or a MAC? Usually a MAC for children, probably a RIC more so in the adults. I'll see what your experience is. TBI versus ATG, we do serotherapy. We do distal serotherapy. And then we do with it, I told you we do a T-cell replete. We do a PTCy approach with the Hopkins. We give our cyclophosphamide at D+3, D+4. We spoke about the GCSF priming bit, right? Again, I'll show you because my fellow is working with me on this right now. We're looking at the infectious spectrum with these haploidentical, and we have seen that if you are coming in for especially our SCIDs, by the time they get referred to us, if they are coming in with a raging CMV or an adeno, their outcomes are much poorer as compared to those who are naive, infection naive. And of course, then the journey continues. And you have to deal with hemorrhagic cystitis. Of course, you're giving doses of cyclophosphamide after that. Usually, I think we have gotten in trouble where we have also, given them TBI. That's where we have had like really bad hemorrhagic cystitis to deal with. VOD has been an issue for us, especially in our HLH cohort, and that's why we have moved from BU base to a triosulfan base. And initially, we were giving them defibrotide prophylaxis, but after the data on the prophylaxis, we only give them defibrotide if they have VOD. We've diagnosed them with VOD. So we spoke about the conditioning regimen, right? And then how do you escape? So relapse mechanisms. I mean, again, still not fully understood, but the thoughts are maybe, losing the unshared haplotype that's how, the malignant cells escape surveillance. Now, infection risk we spoke about, right? So we're giving them a haplo. We have to have them heavily immune suppressed. And then we end up with all these viral infections. So practically speaking, I will see what you guys have to say. But what has gotten us into trouble is CMV and BK and adeno. And then, it's a vicious cycle because you have CMV, then you have given them all this conditioning. And on top of it, you want to offer cidofovir, you want to kill off their kidneys completely, and they're on calcineurin inhibitors. So it becomes a very tough situation to deal with post-transplant. So occurrence of EBV, PLTLD, we have never seen any. We are using T-cell replete grafts, but of course, okay. Oh yes, this is what I was talking about. So this is just data from our center. I mean, we're still working on the paper, but I just pulled up a few graphs. So this is when you have pre, and this is when you are coming in naive. So you see the difference between their outcomes. Cost effectiveness. So you never forget money because money is a major player. Anything that you want to do in your center, irrespective of whether it's transplant, non-transplant, health economics after the COVID. I mean, it's really hit hard, and I think we really need to factor that in whatever you plan or you see as a vision for your center. Again, we spoke that size pretty cheap, easy to do as compared to graft processing, right? I think what Dr. Hamdani was talking about, buying, training, manpower, will they leave you? Will they stay with you? How does it work? But then, even if we do a simple PTSI approach, we have to be ready to deal with the complications, which again are not expensive and come at a cost. And if you're going to be thinking of a T-cell depleted approach, then you really need to make sure that you do have the appropriate CTLs, vital CTLs to deal with those complications. So I just took a snapshot. I mean, because I'm actually grateful for my colleagues. They're waiting for their data to mature. But this is Ayas Mahab. He's well known for Fanconi and his experience in transplant for the Fanconi kids. And if you see, this is the EBMT data, and this is an aggregate from all the centers they've gotten. And so they're averaging on their overall survival around 80%, and that's what we are matching with. I think he is probably working on the manuscript, and that should come out soon. So I think we're doing pretty well, I would say. I'm a little biased. This is our practice for aplastic. Again, I'm thankful to our aplastic group for sharing their slide. This is the Chinese data. And, it's averaging around 80%. Now, what gets us into trouble is our malignancies. Our leukemias are not doing so well. And that's why, we're using the CAR T-cell approach, and we're trying to see how else to improve the outcomes for our leukemics. But the overall, if you look at it, the p-value is not significant, but our non-malignants are much better with our haplo approach as compared to our malignant pediatric population. So in conclusion, I mean, what should we take away from this talk is Haplo is an established entity. I think for resource limited countries like ours, I think investing and gaining experience is it's the way to go. At least I'll be happy to see what others have to say. Then the outcomes are matching and to that with the siblings, because the more you do, the more you learn, the more experience you get, the more you can improve your techniques and your practices. PTSI, very easy to do, cyclophosphamide, no fancy machines or fancy things to do in your lab. But of course, the money that you're going to invest in the post-transplant care is important. But again, you can't downplay the exceptionally low rate of chronic GVHD and the quality of life that you get with T-cell depleted approaches. I think this is my last slide. Thank you all, guys. Thank you.
Will we take questions at the end? So
I'm happy however you want to do this.
Yeah, we'll do questions at the end.
Okay.
Thank you. So our next talk is from Dr. Raheel Iftikhar. He's an associate professor of medicine and a consultant clinical hematologist and a transplant physician at Armed Forces BMT Center. He's going to give us a talk in updates in management of gastrointestinal related GVHD.
Bismillahirrahmanirrahim. Thank you very much. I'm indeed highly honored to be presenting today at this August forum. And I'll be discussing updates in the management of gastrointestinal tract acute graft versus host disease. There are no disclosures or conflicts of interest. William Ockham was a famous philosopher of 14th century who proposed this hypothesis that if you have two competing ideas to explain the same phenomena, you should prefer the simpler one. And we in transplant community are often faced with the challenges and we have to take some decisions. We know that graft versus host disease occurs in around 50% of the patients receiving allotransplant. And it is a major cause of morbidity and opportunistic infections are prevalent. If you look at the causes of death after allotransplant, for HLA match related transplant, graft versus host disease is responsible for around 17% of the deaths and around 20% in unrelated donor transplants. So it is a significant cause of morbidity and mortality post-transplant. If you look at the organ involvement in acute graft versus host disease, gastrointestinal tract either alone or in combination is present in around 76% of the patients who suffer from graft versus host disease. So a major burden of the patients with graft versus host disease, which we will be facing in our clinic, will be having gastrointestinal tract involvement. If you look at the pathophysiology of acute graft versus host disease, we know that it follows a three-step cytokine model in which initial tissue damage by conditioning chemotherapy causes release of inflammatory cytokines, broadly TNF-alpha, IL-1, IL-6. This actually stimulates the host antigen-presenting cells, leading to donor T-cell activation. And it is this donor T-cell activation which in turn leads to involvement of effector organs, which in case of acute graft versus host disease, we know are skin, liver, and gastrointestinal tract. In case of intestinal graft versus host disease, in addition to this three-step cytokine model causing tissue injury, another important contributory factor is dysbiosis, which occurs as a result of antibiotic use of TPNs, increase in lactoses. Both of them leads to increased bacterial translocation, worsening of existing intestinal microenvironment, leading to GVHD exaggeration and trigger. If you look at the target cells of intestinal acute graft versus host disease, these are intestinal stem cells, Paneth cells, and enterocytes. Damage to these three primary target cells in intestine then leads to release of pro-inflammatory cytokines and again, altered expression of antimicrobial proteins in gastrointestinal tract, leading to signs and symptoms of graft versus host disease of intestinal tract. The differential diagnosis that we see in gastrointestinal tract graft versus host disease is broad, and it ranges from the effect of nauseating medications, residual effects of conditioning chemotherapy, to viral infections in case of upper gut graft versus host disease. While in lower gut graft versus host disease, again, There are myriad conditions which can mimic graft versus host disease. The treatment of these conditions as compared to GVHD is poles apart. So it is very important to have a clear-cut diagnosis, which we should have in hand before we are offering treatment to our patients. However, there is no single investigation that can reliably confirm or refute the diagnosis of gastrointestinal tract. We frequently rely on histopathology, but in next slides, we'll see what are the caveats. So it is a combination of clinical presentation, exclusion of secondary causes, gut imaging, serum biomarkers, endoscopic examination, and typical histopathology, which ultimately leads us to our diagnosis. If you look at the clinical presentation of upper gut graft versus host disease, the clinical findings are highly non-specific. Anorexia, dyspepsia, food intolerance, nausea, and vomiting can be seen in virtually any patient post-transplant due to effect of conditioning chemotherapy, multiple medications which we are giving to them, and they can be the first manifestations of upper gut graft versus host disease. Less commonly, gingivitis and mucositis, which we frequently ignore and attribute again to our chemotherapy medications, can be the presenting symptoms of upper gut graft versus host disease. And it is very important that we have an early diagnosis, because the failure to recognize upper gut graft versus host disease then leads to progression to symptomatic lower GI involvement with a higher grade at presentation, which then becomes frequently difficult to control. For lower gut graft versus host disease, the common symptoms which you see are diarrhea, hematochezia, and abdominal cramping. The diarrhea is often mild to severe, can exceed more than 10 liters per day, and is characteristically secretory diarrhea, and it continues despite fasting. That often is a clue in our patients about development of lower gut graft versus host disease. Hematochezia and abdominal pain is frequently seen and again correlates with the severity of graft versus host disease. So once we have symptoms or clinical presentation that actually that make us think that our patient may be having graft versus host disease, then most of us then proceed to endoscopic examination. But again, the endoscopic findings are non-specific. Sometimes the patient does not allow us to have endoscopic examination because of the clinical signs, symptoms, which we hand. So most common manifestation, endoscopic manifestation of upper gut gastrointestinal tract graft versus host disease is diffuse erythema, ulceration, and bleeding, which again is non-specific and can be seen in a number of conditions. The most important differential in this case is herpetic virus infection, either CMV or HSV. And we know that even these viral antigens coexist with graft versus host disease. So it is important that we should discuss with our histopathologist that IHC for viral antigens should always be applied to all the endoscopic examination, the histopathological samples, which we are sending for graft versus host disease. In case of lower gut graft versus host disease, the GI examination findings are again non-specific, ranging from edema, redness, erosions, ulceration, villus atrophy, vascular permeability, the tortoise shell mucosa, and mucosal ulceration, which is seen in advanced cases. We often rely on histopathology to confirm our diagnosis. However, histopathology is not the gold standard. The false negative includes sampling error, the patchiness of GVHD-related abnormalities, and absence of early histological abnormalities, which we encounter in our patients. And above all, in most of the centers, there are lack of expertise of our histopathologists about GVHD-related abnormalities. And we have seen it frequently at our center that early abnormalities are often reported as inflammatory findings, non-specific colitis, which then later proves out to be graft versus host disease. For lower gut graft versus host disease, we are often actually facing that dilemma that patients are mostly symptomatic, they may be severely thrombocytopenic, and the colonoscopic examination is not feasible. Rectal biopsy has shown high sensitivity for lower gut graft versus host disease and is now considered a go-to test for all the patients in which lower gastrointestinal tract GVHD is suspected. And if it is negative, we should proceed to colonoscopy, which is more invasive and sometimes difficult to be done. Another important finding is that it has to be discussed with our gastroenterologist as well, that around 60% of the cases in which the endoscopic findings are negative, there is microscopic involvement of graft versus host disease. So it is important to reiterate that normal endoscopic naked examination does not exclude graft versus host disease. And we know that with severe disease, whole of the areas may be denuded with total loss of epithelium, a finding that is similar to seen that we see in skin GVHD as well. So this is a typical histopathology of acute graft versus host disease that we see, characterized by presence of apoptotic bodies and non-specific cryptitis with inflammation in the mucosa consistent with acute graft versus host disease. Imaging is often overlooked once we are making a diagnosis of graft versus host disease. However, in certain cases in which endoscopic examination and histopathology is not possible, GI imaging does give us a clue where we are heading. So the characteristic findings that are being reported in gastrointestinal graft versus host disease imaging finding is the one we label it as ribbon sign, and it is characteristically loss of villi and loss of features of small gut, and the gut is erythematous, swollen, mucosal edema with characteristic loss of feature, the featureless gut, what we say, known as ribbon sign. PET scan is not frequently used for graft versus host disease diagnosis, and it is not considered as a standard investigation. But the upcoming data has shown that PET imaging actually correlates with the extent of involvement, the severity of involvement, and even histology. So this was a study that was conducted by Martin et al., in which they correlated non-invasive assessment of graft versus host disease, and they have actually put forward the role of PET scan for these cases. Serum biomarkers are in field over the last decade, but there were difficulties in validating them. But now REC3 alpha and ST2 are extensively being investigated. They are released by Paneth cells and enterocytes, and they correlate with severity of graft versus host disease and also response to treatment. And even in revised MAGIC criteria, these biomarkers were incorporated. Fecal calprotectin, we know, is again a marker that was historically used in inflammatory bowel disease as a marker of response to treatment and severity. In graft versus host disease, it has shown to correlate with the severity of infection and response to treatment. And the levels that were seen in graft versus host disease were higher than what we see in GI infections. So it can be a useful surrogate marker in difficult cases. So the diagnosis of acute graft versus host disease can be readily made on GI manifestations in the absence of alternate cause, suggestive histopathology, and with or without classical rash or liver involvement. That actually gives a more support to the diagnosis of graft versus host disease. We know that Glucksberg criteria was modified and MAGIC criteria was put forward. The two major important changes which were made in MAGIC criteria was the introduction of upper GI abnormalities and the number of stools per day that were incorporated in order to grade the severity of graft versus host disease. If you look at the factors which affect overall survival in gastrointestinal tract graft versus host disease, age more than 18 years, presence of steroid resistance, presence of bilirubin more than 3, and overt GI bleeding, both of them definitely correlating with the severity of graft versus host disease, are associated with poor outcomes. And for patients who have more than 3 factors, we have seen that the outcomes are dismal. The treatment goals we have in graft versus host disease is improvement or stabilization of organ manifestations, limitation of long-term treatment toxicities, improvement in functional status or quality of life, and with the ultimate goal of improvement in overall survival and GVHD-free, relapse-free survival, what we call as GRFS. EBMT and ELN treatment recommendations were put forward first in 2014, and on the basis of clinical signs and symptoms, patients who have grade 2 or more acute graft versus host disease are started on systemic methylprednisolone 2 mg per kg per day for 7 days. And if there is concomitant GI involvement, non-absorbable oral steroids are added. For patients who have major improvement, the steroids are tapered off. However, there is no consensus on the optimal rate of tapering, and the treatment is stopped when all the signs of graft versus host disease disappear. And if there is no response or clear progression, patient is labeled as steroid resistance, and we move on to second-line therapy. With regard to gut graft versus host disease, there are a few important points which needs to be considered. That once what we have discussed previously as well, and what we frequently see in our practice as well, that it is relatively common for patients to have both GVHD and viral infection. For example, CMV colitis, CMV gastritis, esophagitis, herpes esophagitis, and it needs evaluation at the time you are starting GVHD specific therapy. For isolated upper gut GVHD, a lower dose of corticosteroids is recommended. All the patients on active graft versus host disease treatment should be on antifungal prophylaxis. Supplemental nutrition should be provided to all the patients who have upper or lower gut graft versus host disease. Octreotide, we have seen frequently results in symptomatic improvement and actually serves as a useful bridge before the steroids take over. The role of non-absorbable steroid was documented by McDonald's et al., in which they documented that addition of budesonide to prednisolone resulted in higher responses at day 30 and day 40, and it translated into better GRFS as well. And it also enabled to lower the doses of systemic steroids, and the risk of secondary infections were lower as well. For GIT graft versus host disease, once we have started our patient on systemic steroid and we are giving GVHD specific treatment, it is very important to direct our treatment regarding to gut as well. Nutritional support is very important. Both micro and macronutrients should be replaced aggressively in all these patients. There's a tendency among transplant physicians to advise complete gut rest in all the patients who have graft versus host disease. However, it is preferable that enteral nutrition should be continued as long as the patient is tolerating it, because it results in early reepithelialization of gut mucosa. And if the patient does not have grade 4 graft versus host disease, complete gut rest should be avoided. All the patients should be on parenteral nutrition if they have more than 500 ml per day of diarrhea, and early introduction of enteral diet is important. Once we have started the patient on treatment, it is important to assess for symptoms and for emergence of infections, which we frequently see in our setup, that patients of graft versus host disease, once they are started on immunosuppressive treatment, there is emergence of infectious complications. The formal assessment is done at day 5 and 7. If the patient is steroid refractory, if there is progression at day 3 to 5, or if there is no response at day 7, patient is labeled as steroid refractory. So progression at day 3 to 5 or no response at day 7, we label the patient as steroid refractory. For patients with steroid refractory acute graft versus host disease, there is no consensus regarding standard second-line treatment. However, JAK inhibitors are gradually becoming the standard of care second-line treatment across the globe. It is because of their important pathogenic mechanisms in all the 3 stages of GVHD pathogenesis, which we had discussed previously, that conditioning treatment, mucosal damage, donor T cell activation, and affected tissue damage. In all these 3 cytokine pathways, graft versus host disease can be prevented, the symptoms can be reduced by introduction of JAK inhibitors, because JAK-STAT pathway is a major player in this regard. And we all know that REACH trial was the trial that actually, it was a phase 3 multi-center randomized open label trial that compared ruxolitinib in a dose of 10 milligram twice daily to best available therapy. And partial or complete responses at day 28 were 62% as compared to 39% of best available therapy, with higher incidence of treatment-associated adverse reactions, and most common of that was thrombocytopenia. A major concern with ruxolitinib and graft versus host disease of gastrointestinal tract is always whether ruxolitinib will be effective in patients who have GI involvement or not. The subgroup analysis of REACH2 trial documented that there was no difference in overall response of different organs, whether there was gut involvement or not. And studies subsequently have also shown that irrespective of the type of organ involved, the overall response rate remained the same. So for steroid-resistant acute graft versus host disease, ruxolitinib is preferred based on superior efficacy and modest toxicity in a phase 3 trial comparing ruxolitinib with best available therapy, and is now more oftenly used as a standard of care second-line treatment. This is the data from our center in which 38 patients of steroid refractory acute and chronic graft versus host disease were given ruxolitinib, and the overall response rate that we had documented was 85.7% in acute graft versus host disease, with a complete response rate of 28.5%. And out of those, 34 patients had GIT involvement, and overall response in this cohort was 82.3%. Beyond ruxolitinib, there is no standard of care second-line treatment, and different institutes are using different drugs based on their institutional experience and preference. Etanercept has documented gastrointestinal responses ranging from 50 to 70%, with around 50% complete response rates. Extracorporeal photopheresis was traditionally being considered as a treatment for skin graft versus host disease, but subsequent data has shown responses in liver as well as gut involvement. So this is a meta-analysis of different studies of extracorporeal photopheresis, and if we see, the responses are variable, ranging from somewhere between 40% to 75%. Basiliximab is an IL-2 receptor antagonist that has also shown efficacy in few of the studies in patients who had steroid refractoriness. Beyond these second-line traditional therapies, what is in the horizon? Fecal microbiota transplantation, anti-complement therapy, alpha-1 antitrypsin therapy, recombinant interleukin 22, and anti-integrins are all being used and tried. Alpha-1 antitrypsin is a circulating proteasome inhibitor that protects tissue from proteolytic degradation, and it suppresses pro-inflammatory cytokines. This study, which was published in 2018, documented that at day 28, around 35% of the patients had complete response, and around 25% patients had partial response to alpha-1 antitrypsin in steroid refractory graft versus host disease, with an overall response rate of around 60%. Mesenchymal stem cells have long been tried in different diseases, and refractory gut graft versus host disease is one of them. So this was a study which was published in 2008, back in 2008, in which complete response rates of 50% were documented with the use of mesenchymal stromal cells. Subsequently, different studies actually failed to document any benefit of mesenchymal stem cells, and there was data that is variable between different studies. We conducted a pilot study in 2016 and carried it till 2021 and published in 2021, in which we used mesenchymal stem cells in steroid refractory graft versus host disease in 10 of our patients. And the overall response rate was 80%. 2 patients had not responded, 5 patients had complete response, and 3 patients had partial response. And this was the cytokine analysis of this study. After the dose of mesenchymal stem cells, there was a marked reduction in pro-inflammatory cytokines in our cohort, and it actually causes reduction in interferon gamma, IL-1 beta, IL-2, IL-6 levels. Fecal microbiota transplant is frequently being tried over the last few years and has documented response rates as high as 56.5% complete responses and around 70% overall responses in patients with steroid refractory graft versus host disease. So how we manage acute graft versus host disease of gut at our center. This is our guideline algorithm, which we frequently follow. For patients with acute graft versus host disease of upper gut alone, we start at prednisolone at 1 mg per kg, and we optimize immunosuppression with calcineurin inhibitors and MMF. For patients who have achieved a complete response, we taper off steroids over 4 to 6 weeks for malignancy and a slow taper for benign disorders. For patients who have a partial response, we add ruxolitinib, which we are getting free of cost from our support program. And we taper off steroids first, followed by ruxolitinib over 3 to 6 months. For refractory graft versus host disease, we stop steroids, we switch to ruxolitinib, and there's no standard next line of treatment. We have ECP at our center, a facility of mesenchymal stem cells and basiliximab, and we use them interchangeably. For acute graft versus host disease of lower gut, which is more than grade 2, we start at methylprednisolone at 2 mg per kg, and we add oral non-absorbable steroids. If the patient has achieved a complete remission, we taper off steroids over 4 to 6 weeks for malignancy, followed by a budesonide taper. That is, first we taper off systemic steroids, followed by a budesonide taper, and slow taper over 4 to 6 months in case of benign disorders. For partial response, we stop steroids, we continue budesonide and add ruxolitinib because we have seen a very high risk of CMV reactivation in our patients and invasive aspergillosis, especially in lower gut GVHD, in which high dose steroids were given for a long period of time. And for refractory graft versus host disease, we switch to ruxolitinib and then move on. So I'll conclude by saying that graft versus host disease is the most important complication following allogenic transplant and is associated with significant morbidity and mortality. Steroid remains the only first-line agent for management of acute and chronic graft versus host disease. Multiple agents are being used as second-line treatment option in steroid refractory graft versus host disease, but there is no consensus treatment for steroid refractory acute graft versus host disease beyond ruxolitinib. Ruxolitinib has superior efficacy and modest toxicity, which was confirmed by REACH-2 trial. Thank you very much.
Thank you very much, Dr. Raheel. Very nicely elaborated. Now we have Dr. Ayaz Mir. He's a consultant hematologist, hemato-oncologist. He's the chief of bone marrow transplant services in Shifa Hospital. He will give us a much needed talk of a single center experience regarding outcomes of T-cell ALL with hyper-CVAD chemotherapy in adolescents and young adults.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you for the kind introduction. I think one of the reasons this talk is in the BMT session is I get a few consults, quite a few, where people assume that somebody has TALL or TLL, they automatically need a transplant. And as of 2022, that is not standard of care. So we have about 40 patients at our center in the last 5 years of TALL, TLL, and this is a brief introduction of what we experienced. So one striking thing about this graph, this is a population graph. AYA in our center was defined as 10 to 45 years. And there were 0 females. So out of the 40 or so patients we had, highly striking male preponderance. Actually, one of our fellows is looking at all the data we have on TLL, TLL, which is about 80 to 100 patients. And we have hardly 5 females. So somebody needs to take a look with NGS at that Y chromosome. We see a lot of people from KPK, especially in those typical people we see are young males with or without a mediastinal mass. So this is the presentation. About 60% patients had a leukemic presentation. About quarter patients had a mediastinal mass. And then there were another 20% so that were a mix of both. There was functional status was mostly good. 3/4 of patients were ECOG 0, and then some were ECOG 1. White cell count more than 100,000 was once considered a high risk manifestation and merited transplant. Not anymore. This in itself is not an indication for transplant, although outcomes are inferior. A majority of patients, about 60%, presented with high white counts. 1 in 5 will have CSF involvement, and this is very important because this I don't see very often. In our center, we are blessed to have very good flow cytometry backup. Our chief of pathology, Imran Nazir, who's a hematopathologist trained at Yale, has special focus on flow cytometry, and he picks up these ETP, early T cell phenotype, which is defined as CD1A negative, 8 negative, 7 positive phenotype with expression of at least 1 myeloid marker, usually CD1, 17, and 34. So once you have this ETP ALL, this is a very high risk population. About 15% of our patients were in this group identified by flow cytometry, And regardless of the white count representation, CSF involved, this identifies a very high risk group. I have only one patient who has made it to transplant in this group because that is Hagop, Kantarji and others consider this a standard of care for this particular population. We have only one who made it that far. Everybody else did not go into remission. So at flow cytometry, if in our experience, at least 1 in 6 in your center is not coming up as an ETP ALL, we need to focus on that. Somehow cytogenetics were mostly normal. A few had abnormal cytogenetics, and in our data that did not really impact the prognosis. What did we do with them? We gave them hyper CVAD most of the time. So this is the patients who were the green are the who were treatment naive and came to our center. In this group, there is data from MD Anderson showing that although people talk about pediatric and pediatric inspired regimens, in the AYA group, which is again, when you look at the AYA studies, they're defined from 12 to 20 to 40 years. You have to see what they are calling AYA, and we use exclusively hyper CVAD in about 90% of patients. That's what we used. And this is Kantarjian's paper where they show that treatments of hyper CVAD in this group were similar to that of pediatric regimens. A lot of time when I see a lot of patients that come to me who have received a pediatric regimen, I think the crux of pediatric regimen is that the frequent MRD monitoring and early negativity of the disease, and if it does not escalate. And a lot of time I see these patients who are on a pediatric protocol and has never had an MRD in 3 years. So I think that's like half cooked. Just getting the patient on a pediatric protocol with incomplete preconditions is probably not as effective. So in our experience, 97% patients did achieve a complete remission, at least initially. And MRD, we were not able to do in half our patients. A limitation of that is your patient's original flow cytometry was done at an outside center. Some of the centers in US, for example, I was at Penn State, as a policy, they would refuse to do MRD if the original flow was not done. Again, when you say flow, there's an 8-color flow, a 10-color flow, a 12-color flow. So you have to see, and also you have to pay attention to the number of events. The difference between flow cytometry and MRD is the number of events you count. I've had a patient with different MRD from top centers in Pakistan, Shaukat, Khanum, Khan, Shifa, all giving different results of MRD. And the reason for that is you look at an MRD from one center, it is negative, and they only counted 500,000 events. The other center is saying it's 0.02% because they counted 1 million events. So you have to sort of see what the MRD is saying. And if this is positive, this is a high risk feature after 1B approximately, these people should go to transplant. Post-induction, we had relapses, and 2/3 of the patients did well, 1/3 did relapse. Half of them relapsed during the hyper CVAD, so primary refractory disease. And the other half relapsed during POMP maintenance, which we typically do for 2 years. Again, at our center, if you go by the book, first 3 months after I came from US, I was giving people POMP as it was taught to me, and everybody ended up with a pneumonia, severe cytopenias. POMP is not designed for our population, I think. So we do not typically give the 15 to 20 milligram per meter square of methotrexate, the heavy doses of Dexa, 75 milligram per meter square of Puritone. We start lower. I start with 2.5 milligram per week of methotrexate so that they tolerate. The goal is to get them through. After POMP, none of our patients has relapsed. The ones who completed 24 months of POMP, we had 0 relapses. At relapse, people have much more common. The CNS relapse is almost double the original. Again, in this, people have to have 6 negative intrathecal doses of chemotherapy. By 6, I mean methotrexate and RRC combined. If you're doing them separate, 12. For you to stop doing that. So at relapse, we saw about 40% of our relapses had CNS involvement. Only a quarter of our patients were able to get a remission after they relapsed. So with hyper CVAD, the first chance is your best chance. We gave 3 patients nelarabine. Somehow we imported it. None of them made to transplant. One developed paraplegia. It's a very toxic agent, nelarabine. The other two, one developed COVID, and one had severe financial toxicity and basically lived for 12, 13 months after nelarabine, could not undergo a transplant, relapse, and died. POM maintenance, as I said, our mean cycles we were able to give to these 40 or so patients are only 14. Sometimes I have to skip months. They develop a pneumonia, you skip POM. Sometimes they just become so cytopenic you cannot continue. We were only able to take to allogeneic transplant 10% of the patients who had relapsed, and 2 are doing well. One had VOD, and one had, I think, graft failure. We have used radiation therapy for various reasons, for testicular involvement, CNS involvement, and some were TBI-based regimens in 20% of our patients. And this is what we found out. Our OS curves, and this is with a median follow-up of about 2 years, is at 45% or so. This is our progression-free survival curve, slightly better, 47, 48%. And this is from the GRAL study, where overall, this is at 48 months, which is longer follow-up than we had. This survival was 48. At 2 years, it was better. It was like 50%. And this is the study with AYA from Dozer with similar OS PFS numbers as we showed. So in our patients, the people who presented with TALL had worse survival than those who presented. If your patient has a mediastinal mass, the survival is actually better in our study. If they just had the leukemic phase, it's worse. This says count more than 100,000. People with count more than 100,000 do worse, the blue curve, and those with less do better. This is CNS involvement. People with CNS involvement do worse. So kind of food for thought, should all of these undergo stem cell transplant? In pediatric population, there's an answer. In AYA, I think it's still debatable. Early T phase, for sure. Everybody should get a transplant if you can get them that far. This is MRD 1B status. So the green ones did not have MRD testing done for various reasons. Red ones were positive, red negative, and blue ones were positive. So positive MRD after 1B, I think everybody relapsed at month 28. If you had negative MRD, you had a flattening of the plateau. And when we did, this is the HSCT data. This is not ours, AYA. When you do the transplant versus no, the survival is better. So in conclusion, in our data, there is a strong male preponderance. We need to do NGS and find out why. ETP, transplant, MRD after 1B or CNS involvement, probably you should consider transplant. Hyper CVAD in our setup is a viable regimen, although when we looked at everybody, only half the people were able to complete all 8 cycles. It's a toxic regimen, and the cost toxicity to each cycle in our setup costs about 3 lakh. So 8 times 3 is 2.5 million, same price tag as a transplant. And auto HSCT, I think if it were to say one thing, T-cell ALL is not an automatic indication for bone marrow stem cell transplant. There's people you can save without transplant. A lot of credit to Dr. Daniel, who made every single slide of this presentation, did all the statistics. Dr. Khadija, who collected data. They've been phenomenal. Thank you.
Thank you, Dr. Ayaz. So with this, we can start the Q&A session, and there are a few questions lining up. So the first question is for Dr. Sadia. So what is your commonly used desensitization protocol? I presume they're talking about those who have got DSA positivity in the haploidentical transplant setting. And do you repeat DSA titers after desensitization?
We do, and first line is rituximab, and the second one's plasmapheresis.
And you do repeat the DSA after
DSA,
sensitization?
yeah.
Yeah. Okay, so I hope whosoever asked got the answer. Nice and short. So I mean, in our center, we've just started doing haploidentical transplants in adult setting, and we are currently actually not doing haploidentical transplants if they have got DSA positivity, because we've not actually done any desensitization protocol just as yet, but it will be nice to have other views from other centers as well.
I've done one desensitization, it failed. We were not able to bring the DSA below 6,000 MFI. Patients spent 3 million. Where to avoid the cost,
Yeah.
you easily doubles the cost of transplant.
Transplant itself.
Just the key case.
So we have done two. Both of them actually had primary graft failure, and we are not doing it as institute. Actually, there are a lot of other things that are related to desensitization once it has been done, because then we have to check DSA titers immediately before stem cell infusion, then at day -3, day +3, then day +10 till engraftment occurs.
Sorry to interrupt. Can you use the microphone because an online audience cannot hear that? Thank you.
I was just mentioning that I'm working at a transplant center in Rawalpindi, Pakistan, and we had done two transplants who had DSA positivity. Both of them had primary graft failure, and now we are not doing desensitization. There are a lot of logistics involved as well, expertise involved. Like once we have done desensitization and we have achieved an MFI level of less than 5,000 or as per institutional policy, then it has to be repeated frequently till engraftment. And whenever the titer jumps up, we have to repeat that desensitization protocol. So a lot of cost that is involved.
Yep, can you pause?
Ma'am, do you have any experience of haplo and thalassemia patients?
In haplo and thalassemias, yes.
And what about it? How is your experience?
It's very tricky, right? Again, we're still waiting for data to mature, and that's why I couldn't present. These are all snapshots from here and there. But again, what we have learned from our thalassemias is not to use the mothers. We prefer our fathers, and it's still on a trial. So actually, we have an open trial going for haplos in thalassemics, because ethically, I mean, is it worth doing?
I look at the Norepinephrine data and I can tell us he is like 95% probability. It's better than a match sibling data.
Yeah, because but the benign hematology is doing really well with heme. So benign hematology is doing really well with haplos. So I think the thalassemics will match as well.
My other question is from Sir Rahil. Sir, you mentioned in your treatment algorithm of upper gut GVHD that you start with the prednisolone 1 mg per kg, and then if the patient is not responding, then you add ruxolitinib. Is there any reason why don't we give 2 mg per kg, which is the maximum dose? Or you have seen that patient don't even respond to that 2 mg per kg. That's why you don't use 2 mg per kg, or is there any other reason?
Thank you very much. So the data has actually shown across the globe that once you have a isolated upper gut graft versus host disease, you can do equally good with 1 milligram per kg doses. And the studies have shown that increasing the steroid dose beyond 1 mg per kg does not increase the response rate, but the risk of infection increases.
And other question is that you used mesenchymal stem cells in your patients who did not respond to steroids. Did you use any other second line medications before going for mesenchymal stem cells, or you just used as first second line mesenchymal stem cells?
So at that time, ruxolitinib was not available with us. So I don't exactly recall the number, but most of them had received any other second line agent, which we had used at that time. And it was infliximab, mycophenolate, mofetil, and even ATG in 1 or 2 patients. So patient did not respond, and then MSCs were given.
Yep, go on.
Ma'am, I'm Dr. Daniel from Shifa International. I have 2 comments and a question. The first comment, congratulations everyone, we won the match.
Yes.
Bought the cup. My second is we see a lot of engraftment failure prophylaxis in our haploidentical transplants, so much so that our center is actually considering giving CMP prophylaxis to our haploidentical patients. Do you give any form of prophylaxis? One, if you do you see engraftment failure? If not, what are your CMV reactivation rates? Thank you.
Okay, absolutely. So we do use prophylaxis. So our go-to is acyclovir for viral infections. Our go-to is Caspo for fungal. So everyone gets prophylaxis except for bacterials. We don't give any antibacterials beforehand. And then we keep monitoring them twice a week. So we have a CMV detection every twice a week. And as soon as we, with our ID, anything with above 100 international units, we try to treat them. So we, we increase the prophylactic doses of our acyclovers to our therapeutic doses. And then we have also seen, because when we have CMV, we don't only have CMV, we also end up having a bit of BK or a bit of adeno here and there. So there have been times when we have just decided to treat with cidofovir, and my ID colleagues tell me the cidofovir is going to also, cover for the CMV and the adeno. But if we haven't engrafted as yet, and we are going, the trend's not very healthy, we go to foscarnet. We do keep a good eye on the kidney functions, and once we've engrafted, we then switch to ganciclovir.
Yes, so Dr. Haley.
So can experience with that. So it was one of the prospective study that we started in 2016, and it was a topic of one of our fellow, that CMV reactivation post-transplant. So we had an analysis in 2019 in which we had exactly similar findings. The statistically significant variables were use of steroids, use of ATG, and use of valganciclovir. In all these three, not ganciclovir, valgan. So after that, what we did that we tried to reduce the use of steroids to minimum, even as antiemetic therapy in our haplotransplants. From 2020 onwards, we are using ganciclovir as long as patient is indoor. And once patient is outdoor, we are giving reduced dose valganciclovir. And we have initially submitted our data on around 70 patients of reduced dose valganciclovir. So there was no difference in CMV viremia clearance, mean duration, and CMV resistance. So I think because we do not have meberovir, we do not have letermovir, we do not have these options available. So maybe this is one of the option that we have done so, and we haven't seen any problem.
So just to add in, we are also just prophylaxing with acyclovir, but at the higher dose, pre-engraftment and obviously post-engraftment. If they do have CMV reactivation, then our go-to drug is either IV ganciclovir or valganciclovir. Pre-engraftment, it's foscarnet. So that takes me to the next question. So have you come across any of your haplo patients who had all these problems and then developed poor graft function? So how would you tackle with that?
Okay. So, okay, it depends on the situation, right? So it's not only one thing that comes at a time. I wish it was that simple that you could just deal with one scenario at a time. So, okay, I'll give you an example of, we had an infantile ALL, right? And we went with a mother with a maternal haplo. She ended up with bad GVHD. And of course, you get GVHD in the pediatric population, we just automatically jump to 2 mg per kg. We don't play around with the one. And of course, when we escalated the steroids, we came with CMV, with BK, with adeno. We did a marrow on her because her STRs were falling and we were worried that we were going to lose the graft. We were preparing the mother for a DLI, but in the meanwhile, she was also on cidofovir, right? And we thought that the graft functioning was because of all the antivirals we were giving her. Lo and behold, we kept steady, we kept monitoring her. And once we were able to get the adeno and the BK titers down, we were able to pull off the cidofovir. Up came her ANC, up came the counts. We did support her with GCSF. We have romiplastin, so they get romiplastin, GCSF, and we did not need the DLI so far. So her titers are back up again. So again, it's just, waiting and watching and a lot of patience. I know you feel edgy and, what should we do? The parents keep asking you, but I've learned in my little career that you have to be patient, very patient.
We have got a similar patient currently going through. So we've done the same thing. We're waiting and supporting with GCSF and Altrombopag. So he's had GVHD as well. So we're not brave enough to go with CD34 top up or DLI. So we're just waiting.
You're doing the right thing.
So there's another question from Dr. Azhar from Shifa. I guess that's for Dr. Rahil. So the question, in fact, to the panel is regarding gut GVHD and about the association with usage of prophylactic antibiotics and the increased risk of gut GVHD with that. So can you share your experience about prophylactic antibiotics in your transplant, particularly carbapenems?
We are not using prophylactic antibiotics, carbapenems. We used to use fluoroquinolones, but we are not using it at our center for the last 3 to 4 years. So no prophylactic antimicrobials.
Right. So we're still stuck with ciprofloxacin. We somehow still use it. Okay, so Dr. Ayaz, your take on the antibiotics?
Carbapenems and some other groups have clearly shown increased incidence of acute GVHD, alter gut flora. We actually were using ertapenem as prophylaxis. Our hospital, I don't know about other centers, has a very high prevalence of ESBL E. coli, and now worse MDR and XDR keeps getting worse every day. So we did use ertapenem and we did run into a lot of GVHD and we had to stop that protocol. Right now we are using Cipro. I'm still not brave enough not to offer anything in terms of antibiotics. Every single center I have worked at does prophylactic antibiotics for BMT patients, but it does seem to increase risk of GVHD.
If I may ask a question, just to follow up.
Sure.
What about, have you looked at nutrition, parenteral nutrition versus enteral nutrition, and is that a factor for your gut GVHD?
So not in our patient, we haven't looked at this.
Okay.
Unfortunately, up till recent now, there was no setup for total parental nutrition itself within our transplant center, and we have to actually get it done from outside and then use it. So we haven't looked at this aspect.
So one more question that's directly for Dr. Ayaz from Dr. Farooq Ali Khan. So commenting on wonderful presentation, really encouraging outcomes of hyper-CVAD in TALL. Question is, hyper-CVAD is usually given 3 weekly if count recovery allows. So did you check MRD on day 21 after arm A of first cycle or day 28 of induction as we do in PEDS inspired protocols, or MRD was done only after completion of both arm A and B?
So typically around day 42. So after, just before your 2A is when we do our MRD.
So 1A, 1B, and just before the 2A, right? Yeah. So I think that's all I have questions wise. Any other questions from the audience? Yeah.
Assalamu alaikum, everyone. I'm Halima. I'm a pediatric oncologist. I don't want to take time away from the BMT questions, but I had TALL questions. So for pediatrics, our expected outcomes for TL, LBL are in the range of 85% or so. So for the AYA group that you showed, it was actually much lower compared to what we expect in pediatrics. So as I just wanted to ask about that, then why not treat them on the pediatric protocols? Because pediatric outcomes are so much better, at least in terms of the numbers that you showed today. And the other thing with it being mostly males, what we've seen at Shaukat Khanum, at least over the years, is initially we were seeing a male predominance, and as awareness has gone up, that has sort of leveled out for a lot of our malignancies. And I'm just wondering if it's a social factor more than the Y chromosome, and if you're seeing a similar pattern in other malignancies. Because that's what we saw, like for rectoblastoma, it was 2:1. And then we did a lot of awareness, patient numbers went up, and now it's 1:1 for males and females. So just curious about what your experience in other malignancies is.
One of the things we learned about ALL, especially, is that the outcomes are very diverse just based on age. The 5 years old ALL versus the 15 years old versus the 45 years old really are different diseases. So I think 45 to 50% based on the data I presented is acceptable outcome. The ease we find and our patients find with hyper-CVAD, every center setup is different. The first question I get on day 1 is, Doctor, what is the plan and how much will it cost? So when you give them the pediatric protocol of day 65, day 78, day 104, that's hard for me to understand. And also the cost is there's initial induction phase. So I was trained on, in US, hyper-CVAD is used in almost all adolescents and adults. and I was trained on a hyper CVAD. I have never given a pediatric protocol. But the reason we do this, there is data, at least from MD Anderson, single center data, that's the largest center in the world, that it is comparable in outcomes. I again think the other mistake is to compare the outcomes of, the way they do, for example, in hyper CVAD. None of my patients in US ever had to stop treatment because they can't afford it anymore.
Yeah.
We tell them the cost of cycles, but then they get neutropenic fever on day 13 and a 1 hour ICU, 1 week ICU admission, and all bets are off. So I think we treat a very difficult disease. Definitely our pharmacogenomics and our genetics and our epidemiology is different from what we see in the West. In West, for example, in lymphoma, we used to see a lot of SLL and CLL. That was the bulk of our clinic. DLBCL is 1/3. Here, 50 to 60% of what we see is DLBCL. So I think we need to have, the other day I saw a 29 years old with myeloma. I have never seen a 29 years old with myeloma in US. I have a dozen patients who are 33, 32, 35 with myeloma. I have never seen that in US. So there's something, whether it's genetic or geographic, and but we see a lot of people from KPK. I see a lot of in Pathans, young cancer, aggressive cancer. In the age group, it shouldn't be. We don't have that. So in summary, I think I would still go in our population. That was the reason we did this, because some of our colleagues who come from abroad, they insist, no, you should be doing a pediatric protocol, even in adults, a pediatric inspired. We think that based on our training and our data, we have comparable outcomes. Can we do better? Absolutely. With TLL, some of our older TLLs where we cannot do hyper CVAD. I have 2 patients right now. We're using mini hyper CVAD with daratumumab, venetoclax, and pegaspargase upfront. And this is a regimen again inspired from MD Anderson. We discussed with Dr. Kantarji and his team. So there's not a lot of good answers, but I don't feel that in our you're comparing a less than 10 years old population to people in their 20s and 30s.
So I'm wondering, do you have a breakdown for under 18? Because most of our TLs, we see a lot of teenagers. So they're above 10. They're in the 10 to 18 range. That
young male is the typical presentation at our center. Majority of our patients were in this age group.
Dr. Yas, do you keep them inpatient with hypercVAD?
No, we can't
how long?
afford.
How many days do you keep them in?
During hypercVAD, 4 days inpatient, then outpatient with alternate day CBCs. Same for AML, 7 days infection, then outpatient. APL, as soon as the platelets come, everything else is outpatient. We are on a cost cutting, it's very expensive. I would rather have my patient complete their cycles than to quit after cycle 2, which sadly sometimes happens because president. There's no background.
Dr. Natasha has a question.
Yes.
So I have a question for you, Dr. Yas. Thank you very much for that excellent presentation. So we at AKU have used MRC UK LL12 protocol, and adults, the kids, they go on BFM, but we've used it in adults and we've had excellent results, 50-60% remission rate. We've published the data as well. This is regarding the maintenance treatment. So we've recently switched in high-risk patients to MRC11 because the maintenance treatment for males in that protocol is for 3 years, taking care of the testicular relapse. And for females, it's 2 years. Do you follow the same for?
No. So there's data of 36 months of maintenance versus 24 months of, there's even data of less. Or if you notice in our population, the average months of POM completed were actually 14.
Yes, because of the neutropenia.
No, we do not use different regimens for males and females, but there is data to support that. And again, as I said, if you look at POM papers, actually many of them recommend maintaining ANC around 750, yes. TLC around 2000 for full POM. That
to suppress the lymphocytes.
Not practical. And remember, for the last 3 years, we have been through COVID epidemic. Yes, so our goal was to keep our patients out of hospital, right. And we compromised doses. I don't remember the last patient I gave full dose POM. Okay. Our population, we need to have local data. Our population.
So I think I want to comment on POM maintenance as well from our center. So we have used POM maintenance in the past as well. Obviously now we're using pediatric protocols. So with POM maintenance, we had the same experience. But what we are doing is that as we have got most of our patients are really young. So they're 18, 19, 20, 21. So what we are doing is that we are starting with the standard dose. But the moment they get any cytopenia significantly or any side effects, we reduce it down. And usually by 10 months, 12 months, most of them have got a reduced dose. Steroids needs to be reduced. Obviously, methotrexate needs to be reduced, and mercaptopin has to be reduced as well.
See, half our lapses were during farm. So maybe